Hi everyone, and welcome to ECG a Day. Here we'll go through a single ECG and the discussion will be at an intermediate level. Here is the ECG, and you can go ahead and pause the video at this point and see if you can interpret this ECG yourself before seeing the solution. My approach to this ECG is to first identify the problem. And as you can see on the left-hand side here, we have a tachycardia that is wide. This is a wide complex tachycardia, which will be the problem that we'll be dealing with. Then we have a termination of the tachycardia and a couple of beats of narrow complex sinus rhythm. So if you look at this narrow complex sinus rhythm, I don't see any pre-excitation there. So this is quite helpful, and you can see it. I can see P waves very clearly in V1. So differential diagnosis for a wide complex tachycardia on the left-hand side here is always the same. It's VT, SVT with aberrancy, pre-excitation, artifact, and pacing. I don't see any pacemaker spikes, and this is a very clean tracing, so I don't suspect this is artifact. And this does not look like a typical pre-excitation pattern. And we have a baseline ECG here, and it does not look pre-excited at all. So the top and differential is VT versus SVT with aberrancy, or rather SVT with some sort of bundle branch block. To remind you, the tools we have to distinguishing VT from SVT with aberrancy is those three. So the first and the best tool is the AV relationship. The second tool is initiation or the termination, and we're fortunate enough to have a termination here. And the last and the least helpful often is the QRS morphology, which is largely probabilistic, as I mentioned before. You really need to decide how good of a bundle branch block it is. So let's take a look at this tracing and how we can use these tools. So I first start with trying to identify P waves, because the AV relationship is the most helpful tool by far. Okay, looking at this tracing, I'm checking all the leads for P waves, but in particular, I know that there's a very good P wave in V1. Okay, so I know that in V1 I have the highest chance of seeing a P wave. And looking at this tracing, I do see some high-frequency deflections outside of the bounds of QRS. Remember, we can't call P waves within the QRS. And I often put my three-prong calipers at the beginning of the QRS in any lead and at the end of the QRS in any lead to make sure the P wave is outside of that, and it is. Okay, so I see this high-frequency deflection, and I also see this high-frequency deflection that's also outside of the bounds of the QRS. So now I have two suspect sinus P waves. And the sinus rhythm, it's very good at marching on time, okay? If these are true sinus P waves that are dissociated, then the next one will be, if I caliper out the next beat, for example, taking that interval, it'll be right here. And as you can see, I do see a bump there in the ST segment that would represent a P wave. And looking back, I see another high frequency deflection here. It's probably also a P wave. Okay, and I oftentimes caliper out two of them and see, is there anything in between? There may be something in between here to make sure we're not missing like a faster atrial rhythm. In here we don't see anything because it's in the QRS, but here's a nice clean ST segment, and I certainly don't see any P wave there. Okay, so this is certainly there is an atrial rate overlying this wide complex tachycardia, and the ventricular rate is much faster than the atrial rate. So this rhythm is driven by the ventricles. This is going to be VT almost certainly. Okay, so at this point I would just stop and call it VT. But if you wanted to use other tools, we can certainly do that. We have here a termination of the tachycardia, and we see this is the last beat of the tachycardia with that's wide, and then we have a narrow beat here at the termination. As you can see, there is a high frequency deflection right here, just before the narrow beat, that is a P wave. Okay, and we have a narrow beat here. So in this case, this P wave likely conducted to the ventricles and created a sinus normal QRS. Okay, and some people would call this a capture beat. Okay, a capture whenever that you see a narrow QRS within a wide complex tachycardia. It's very likely that it's something called a capture or fusion beat. A capture beat is when a sinus P wave gets through the AV node and is early enough to beat the next cycle of VT and depolarize the ventricles completely, and it makes a sinus type QRS, very narrow. That's why you see a narrow beat in a big wide complex tachycardia. So that suggests there's a separate atrial component to this rhythm, that it's likely VT. Okay, and if you see fusion beats, it's if a sinus P wave is late enough, or not early enough, such that it actually comes down the AV node and fuses with the next QRS of a VT. It generally creates a narrower QRS that's a fusion between a sinus QRS and the QRS during VT. Okay, you kind of get an intermediate QRS. That's called a fusion beat. That also suggests VT because it suggests that there's an atrial sinus rhythm that's separate, and it's able to get in between the two QRS complexes. I personally don't like capture and fusion beats. I certainly had to know it for my exams. I know what it means mechanistically, but quite honestly, capture and fusion beats in my mind can still suggest SVT. Okay, if you're certainly seeing narrow beats in the wide complex can suggest SVT, because say it is an SVT or sinus tachycardia, for example, the bundle branch block, and if there's a PVC, it'll fuse with the bundle branch block, and it'll make a narrow beat within your SVT with aberrancy. Okay, so, or if the bundle branch block, say, resolves for one beat, for a couple beats, that would suggest that it's that you would see narrow beats within the wide complex in an SVT. So certainly seeing narrow beats within the wide complex tachycardia, you really have to think carefully about calling them capture or fusion beats. In this particular case, it's very clear because you have a P wave just before it, so I know that this is definitely a conducted QRS. Okay. Certainly, this is VT by AV dissociation or AV relationship criteria, and I needn't go any further. But if you wanted to practice using the QRS morphology, looking at this, we certainly have the baseline QRS, and it looks nice and narrow. So there's no baseline bundle branch block, but we know that sometimes bundle branch blocks can come on when the heart rate accelerates, the rate-related bundles. And looking at V1, the morphology is positive, so it's a positive QRS in V1. So we like thinking our right bundle branch type morphology. And the QRS is a little bit unusual for a bundle. There is, the initial deflection is negative, so it's a kind of like a QR pattern in V1, which is fairly unusual. It doesn't look the worst in AVL. In fact, that there's a good R, and then there is a slow, shallow S wave here. This is quite typical here. So I would say by QRS morphology, there's a couple of peculiarities about it, but there's no slam dunk, which is why QRS morphology is the weakest of the tools that we have. In conclusion, I wanted to summarize the key learning point that seeing narrow beats within a wide complex tachycardia, they're often called capture and fusion beats, and they are created when the sinus beat conducts down the AV node, and if it's timed just right such that it gets ahead of the next VT QRS, it can depolarize the entire QRS and make a QRS that's narrow, or that's supraventricular morphology. And if it's not early enough, it can sometimes get in and it can fuse with the next VT to produce a QRS that's intermediate between a sinus QRS and the QRS of the wide complex tachycardia. So those are called fusion beats. And they classically are a sign of VT. However, in this video, I demonstrated how they're often not too helpful, and you should be careful with using them as a golden rule, because if there is an SVT with aberrancy, there are a number of ways when aberrancy can, or you can get narrow beats within an SVT with aberrancy. For instance, if one of the wide complex beats fuses with a PVC, for example, or if the bundle that's functioning gets slightly delayed to the point that both bundles are equally delayed, and you get a kind of resynchronized QRS that's really narrow in a wide complex tachycardia. So there's still mechanisms in SVT with aberrancy where you can see narrow beats within it, so just be careful with that. Thank you.